Well, hello, everyone. We'll go ahead and get started. I'm especially pleased to welcome Dr. West. Dr. Colin West is a professor of medicine, medical education, and biostatistics at Mayo Clinic in Rochester, Minnesota. He's also the co-director of the program on physician well-being there, one of the first in the country, and a founding member of a biennial conference, the American Conference on Physician Health, that is sponsored by Mayo Clinic, Stanford, and the AMA. Just this week, Dr. West was featured in a Forbes article entitled, "Is the US Healthcare System as Resilient as its Doctors?" We hope to hear the answer to that today. That Forbes article is linked in the supplemental resources that are part of the webinar. So today, Dr. West, as I mentioned, will be presenting on physician burnout. It's not a resiliency deficit. But before, I'd like to add just a couple of other notes. Dr. West is a longtime colleague and collaborator of mine. We've shared the podium at many conferences and collaborated on multiple research initiatives together. So it's just a special pleasure to welcome him today. So Dr. West, off to you.
Terrific. Thank you, Chris, so much. And thank you for your partnership over the years in elevating these issues for the benefit of our colleagues, our patients, our communities, really society as a whole. Looking at the business side of things, I do not have any financial disclosures, so that's easy. For people that are interested in contacting me outside of the session, my email address and my Twitter handle are listed here as well, and I'll have those at the end of the talk in addition to where they are now. So I'd like to start with some background, and many in the audience will already be well versed in this background, but I think it's worthwhile to revisit why we talk about burnout among physicians in the first place, because sometimes people have talked about this idea of getting burned out on burnout, and we get numb almost to what these numbers are about. And as part of our partnership, initially between Mayo Clinic and the American Medical Association, and then in more recent years, extending with Stanford, we've looked at national data on burnout using the Maslach Burnout Inventory, widely regarded as the gold standard for burnout assessment. So this isn't just the colloquial understanding of, well, I feel down, I feel stressed, I feel like I'm burned out. This is actually using validated instruments to get a sense of how prevalent this issue is among practicing physicians in the United States. And what we see here on the red line here at the top is overall burnout, which is defined as experiencing symptoms of emotional exhaustion or depersonalization at least once a week, affecting roughly 50% with some lability over time, but roughly overall 50% of our practicing physicians. Emotional exhaustion, 40 to 50%. Depersonalization, this feeling of becoming callous toward others, treating others as objects rather than people, absolutely antithetical to our professional ideals, not what any of us in the practice of medicine viewed as our goals in our practices as we went through our training processes. A third of physicians endorsing depersonalization. So this is a widely prevalent concern. Beyond that, physicians are commonly dissatisfied with their work-life balance, and they screen positive for depression at rates that are quite concerning. Now, to clarify, these depression screening rates don't suggest that 41% of physicians are depressed. Roughly a quarter to a third of these would be estimated to truly, if clinically put through a depression diagnostic assessment, meet criteria. But even those numbers are concerning. And these numbers, even as burnout goes up and down a little bit in the last decade, have been pretty steady, if not increasing. So the prevalence data here should continue to capture our attention. Now, a related question is, well, but everyone in society is stressed. We've seen this certainly in the last year with the COVID-19 pandemic. All groups of society have been dealing with unprecedented stress. So is there anything different about physicians? Or in fact, are physicians a privileged group because of all of the other advantages that we have in terms of social status, financial security, and so on? And so in our prior work, we've looked at this, and consistently we have found that relative to the employed US population, burnout rates among physicians are higher than among other groups in the population. And in fact, burnout rates among physicians are higher than burnout rates among other highly educated people, not just the general public, but even in subgroups with advanced degrees or working in other high demand disciplines. Physicians are also more likely to be dissatisfied with the interference they experience between their work and their home lives. So there does seem to be something different about physicians, even after adjusting for the increased workloads that physicians have as part of their daily lives. Now, all of that might be important in and of itself, but it's particularly important because there are real consequences of physician burnout. The short summary of this slide is that no matter who you represent as a stakeholder in medicine, there is something about physician burnout that should get your attention. When we think about patient care, burnout has been demonstrated to be associated with medical errors, impaired professionalism, reduced patient satisfaction, and even racial biases. From a healthcare administration and patient care access standpoint, burnout is associated with turnover in your staff and reduced FTE, reduced access for patients, reduced time in clinical medicine. And then from a learner standpoint and from a practice standpoint, burnout's associated with blunted growth in medical knowledge, mental health concerns among healthcare professionals, and even some public safety issues involving motor vehicle crashes and near misses after fatigue was adjusted for. And so burnout as an independent predictor of some of these adverse consequences. And estimates that have been developed in partnership with such groups as the Harvard Business School have estimated that burnout related impacts on staff turnover and reduced hours alone, not even all of these other consequences, cost the US healthcare system in excess of $4.5 billion a year. That tallies to more than $7,500 per physician in this country per year, just from turnover and reduced hour costs associated with burnout. And that number is important when we think about the costs of solutions, because sometimes one of the resistant points to solutions is we can't afford it. Well, we're already paying for this. And rather than thinking that we can't afford to implement solutions, I've argued that we can't afford not to implement solutions because of these costs. So to summarize, when we look at the prevalence data across physicians, we have more than 40,000 medical students in this country who are experiencing burnout at levels that associate with those adverse consequences I just mentioned. We have more than 60,000 residents and fellows and 500,000 practicing physicians dealing with consequential burnout in the United States alone, plus all of our other healthcare and biomedical science professionals. We have 3 or 4 million registered nurses in this country. We have additional national data that suggests that about 1/3 of our registered nurses are experiencing burnout. So add 1 million, that's probably an underestimate, 1 million nurses to this, and you start getting a sense of the magnitude of this issue as a public health crisis. This is not a niche issue. It is a systems issue. When you're dealing with prevalence data like this question becomes rhetorical. Is this rooted in individual problems, or is this really a system problem? All of that is important background to think about how resilience might play into our approaches to deal with physician burnout and promote well-being. And so as people have thought about strategies to promote well-being, these are often first discussed from an individual strategy standpoint. And these are important. It's important that we identify our values, the myth of delayed gratification. We are very good in medicine at holding out, well, next week, next month, next year, we will be able to relax. We will be able to get over that next hill and then be able to recover. And yet there's always a next hill, it seems, for many of us. What matters to us most? How do we integrate our values? How do we decide what our values are? And are we intentional about that? Do we strive to optimize meaning in our work within our individual sphere of influence? And do we nurture personal wellness activities that are very individual? Different people will have different solutions within their personal wellness domains. We have to be able to calibrate our distress levels, however, to be able to implement these activities. I won't go into detail about this, but we've got other evidence from studies that have involved my colleague Lottie Derby as well, to suggest that we as physicians are really quite poor at assessing where we are on our distress curves, and we overestimate our well-being. So even though we sometimes think that we're complaining when we're bringing up these issues of distress, in fact, we are often looking through rose-tinted glasses. But self-care is important, relationships are important, and for different people, there are different aspects of mindfulness traditions or spirituality that can be important. The best advice, though, is to be intentional about thinking about how personal wellness activities fit into your own well-being strategy. All of that said around individual strategies, there is a risk to an exclusively individual focus. And the concern is that this could actually deepen cynicism among physicians and other healthcare professionals through the perceived message that physicians have to toughen up to cope with their working environment, rather than addressing the working environment itself. And so many physicians and other healthcare professionals view what they perceive as an exclusively individual focus on developing solutions as victim blaming. I think that's important because it provides an opportunity to reflect on how physicians and other care professionals as well, but right now my focus is on physicians. How do we get where we are? We often take this for granted. We've done it, we got through whatever our training path was, and we don't really think about it or take a moment to actually reflect on what that effort required. So I want to take a moment here to remind everybody what this involves. There is a rigorous path to becoming a practicing physician. In the United States, this typically involves 4 years of high school, at least 4 years of college, at least 4 years of medical school, 3 to 7 years of residency, depending on which specialty you choose. From there, another 1 to potentially 4 or more years of additional training in fellowship, and then ongoing maintenance of certification activities to stay current for your patients. And it's not just that at every one of these steps, they involve years of commitment. At every one of these steps, we strive to achieve. We are academically inclined, whether we're currently at an academic medical center or not. The nature of our profession is one of sustained intellectual curiosity. And that is both rewarding, but also demanding. And if you tally all of this up, physicians have as part of their careers, baked into the cake, sustained excellence, long hours, and personal sacrifice that's expected at every stage over 15 to more than 20 years of our academic careers. And so within that construct, the idea that physicians maybe aren't tough enough or don't have enough grit, or maybe have not demonstrated strong resilient skills every step of the way, clangs for a lot of physicians. That prompted our question, jumping into some of the research on what we've learned about physician resilience and how it compares with the general public, how it relates to burnout. And what we realized is, although many physicians have this conception that we're already pretty resilient, we're already pretty tough, there's no data on this, or at least there wasn't. Or it was very narrowly defined or very institution specific. So we specifically wanted to learn more about how does resilience among physicians compare with resilience in the general population? And how does resilience relate to burnout? So this could then inform, when we think about individual strategies to promote well-being, what is the place of resilience within those individual strategies? And does this data then inform how we need to move beyond individual strategies to organizational strategies and view burnout and distress in healthcare as a system more than an individual problem? So as part of the ongoing collaboration that I previously mentioned between the American Medical Association, Mayo, and Stanford, we've conducted periodic national surveys of physician well-being. And in 2017, this survey involved more than 5,000 practicing physicians and also a representative slice of the US working population, with more than 5,000 participants in that group as well. I will acknowledge that the response rate for this survey among the practicing physicians is low at about 18%. You can read more about this in the paper that I'll be showing you a cover of here in the next slide. We did use some methodologies to try to assess representativeness of that sample, including wave analyses across different waves of the surveys, and those were supportive of representativeness of the physician sample. It may not be perfect, but there is data to suggest that this is probably a pretty good overview of where physicians are across the country. This ultimately led to the paper. The title is shown for you here, The Resilience and Burnout Among Physicians and the General US Working Population. The author list is shown here with representatives from Mayo Clinic, the American Medical Association, and Stanford. This was published in JAMA Network Open in July last summer. And I'm going to jump, having already introduced the methods a bit, I'm going to jump to the key results here and show you here the summary. You've got the research equivalent of the positive radiology arrow sign here with the circle over the key results. And for the physicians who completed data on resilience and were age matched with the population that was in the US working group, we see that the resilience score here was 6.49 on a Connor-Davidson resilience scale. It has a resilience range from 0 to 8. So the maximum resilience score is an 8. And so for physicians, that average score was pretty high, 6.49, roughly 6.5. In the general public, in the employed general public, resilience was a bit lower, 6.25. And in the two big domains of resilience that are addressed by the Connor-Davidson scale, it's partially obscured by my circles there, but the scores were higher in physicians for both of the subdomains as well. So it was consistently a higher resilience score for physicians than the general US population. So that's the answer to the first part of our question. How does resilience for physicians compare with resilience across the general US working population? And our supposition and the hypothesis that most physicians that you talk with, I think, bring to this discussion is that, in fact, we were able to demonstrate that physicians, even in the midst of those burnout prevalences that I mentioned in the introduction, still have higher resilience scores than the general public. So they have lower, the general public has lower burnout rates, lower dissatisfaction rates with work-home interference, but also has lower resilience. Physicians are experiencing burnout at higher rates, but are also more resilient. When we look at this a bit more deeply and look at how burnout relates with resilience, what we see here are three panels. I'm going to start with the panel on the right, panel C. This is the overall burnout proportion. And what you see here is, I mentioned before that the maximum resilience score was 8. The overall burnout rate in the group of physicians with the top possible resilience score, the most resilient physicians, 30% of those physicians were still experiencing burnout. Now, as resilience dropped, we saw burnout rates rise in a monotonic fashion. And so the lower the resilience score, the higher the risk of burnout. And that's an important take home. And some of these numbers are frankly frightening. Physicians with resilience scale scores below 50%, 4 or lower, more than 70% of those physicians are experiencing burnout. The same pattern holds when we look at the subdomains of burnout: emotional exhaustion and depersonalization. So again, even those who are most resilient had meaningful rates or scores in the emotional exhaustion and depersonalization domains. But those scores got worse as people had lower resilience scores. And so we'll talk in the next slide or two about how we take these two pieces of information and link them together. Physicians have higher burnout rates than the general public. They have higher resilience scores than the general public. But as resilience increases, burnout rates go down up to a threshold where at the maximum resilience score, there is still appreciable burnout. So that's really the summary of the data. So in text, what this means is that on average, relative to the US working population, physicians do not have a resilience deficit. Burnout rates are lower at higher levels of resilience, however, and even at the highest possible resilience score, the burnout rate's still 30%. So there's nuance to this interpretation. This means that resilience is important, but we need to be aware that physicians are pretty strong here already. We do need to maintain and even strengthen our resilience where we can. And certainly addressing well-being within our local sphere of influence, our personal sphere of influence, is important. This is part of self-care. This is part of bringing our best selves to our patients and our communities. And it is part of the shared responsibility between individual physicians, their organizations, and the healthcare system as a whole. However, individual focused solutions such as resilience training cannot be the mainstays to promote well-being. Even the most resilient among us are at substantial risk of burnout. Organizational approaches to improve the working and learning environment are mandatory. And if the only solutions that physicians and other healthcare professionals see being offered require that they invest individually in getting tougher, getting stronger, getting more resilient, we are misdirecting our solutions because the individual is not where the bulk of the deficiency or problem is. This is primarily an organizational responsibility. So if we put this in the laps of our organizations, how can we think about organizational solutions? And in broad terms, it's certainly helpful for organizations to be intentional about values the same way we've recommended that individuals be intentional about values. Being value-oriented and promoting the values of the medical profession that all of us have agreed to in broad strokes with our professionalism contracts. Organizations need to promote those values, and there needs to be a congruence between those values and what physicians actually experience in their practices and what their organizations expect. This means that resources need to be provided to adequately support individual physicians in achieving those goals for themselves and for their patients at the organizational level and at the more local work unit level. Sometimes this means maximizing efficiency. Sometimes this is other elements of resource. Promoting autonomy is important. Physicians need a sense of flexibility and control. This is not to suggest that physicians need to be micromanaging every aspect of their days. But physicians can bring the best care for their patients forward when there is some flexibility. And that sense of control, that sense of being an active partner in what the physician's work life is like, promotes well-being. It promotes physicians and other healthcare professionals that can better serve their patients. Work home integration, we've already mentioned, and ultimately what I call the MVPs of well-being, meaning, values, and purpose, are what need to be promoted as a top priority for our organizations. This has been summarized in other forums as well. The 9 organizational strategies to promote well-being that Tate Shanafelt and John Noseworthy, our past Mayo Clinic CEO, wrote about several years ago, also summarizes these organizational strategies from at the top, acknowledging and assessing. Implicitly written here is measuring the problem, all the way down to facilitating and funding organizational science to better understand all of these drivers. I'd also like to highlight from November 2020, a publication from the National Academy of Medicine. This working group was led by Dr. Sinsky, and they put out a paper on organizational evidence-based and promising practices for improving clinician well-being, really with a focus on the organizational solutions. The National Academy of Medicine, now extended to the National Academies of Science, Engineering, and Medicine, has really done an incredible amount of work in the last 5 years to advance our understanding and our advocacy around clinician well-being. And this is an example of how this work can inform our organizational processes moving forward. They identified 6 broad domains. In our Q&A session, I suspect Chris will be able to expand a bit on some of these as they come up in our discussion. But organizational commitment comes up, assessment comes up. This is really tied closely to leadership. We have a growing literature base to suggest that, to no one's surprise, really, leaders have a major impact on physician well-being. And leadership scores, leadership ratings, collaborative servant leadership helps promote well-being. And leaders who, by and large, are well-meaning and well-intended need to continue to develop those skills so that they can help connect their physicians with meaning, values, and purpose. Policy at the local and national level is crucial, and there are active advocacy efforts going on in that regard. Working on efficiency of the work environment. Many of us jump to our electronic health record systems when we think about efficiency, but this goes beyond that. This is also about accreditation standards. This is about working with prior authorizations, anything that Mark Linzer has termed the hassle factors within medicine. Others have called the pebbles in our shoes as we're trying to get through our days to connect our patients with better lives, and ultimately supporting our clinicians toward our shared goals. I really like this figure that comes from the International Consortium of Organizational Resilience. It's a reminder that resilience can be viewed as an organizational strength, not just an individual characteristic. And so this idea of organizational resilience, how are we adaptive as an organization? It's a good opportunity to go back to the basics and say, well, what is resilience? Perhaps should have defined this at the very beginning, but a common definition is that resilience is the collection of personal qualities that enable an individual to adapt well and even thrive in the face of adversity and stress. Well, every aspect of that definition can be adapted to organizations. Resilience is the collection of organizational qualities that enable an organization to adapt well and even thrive in the face of adversity and stress. And you see in this figure some of these key elements that align beautifully with what the NAM paper has suggested. A focus on leadership and strategy, preparedness, risk management, and critically, culture and behaviors that are aligned with our shared values as a profession. We'll have a deeper opportunity to talk, I hope, in the Q&A session about some of these aspects. But again, to summarize, we now have evidence to support the notion that physicians bring greater resilience to their work than the general US working population, despite having higher burnout levels. Individual resilience is important. We certainly need to maintain our individual strengths, but we need organizational help and a focus on organizational resilience to truly allow us to thrive. My email is here. My Twitter handle is here. We will turn to the Q&A in a moment, but I know Dr. Sinsky has a few additional AMA resources and comments to address. So I'm going to advance to those and let Chris take over for a moment.
So thanks so much, Colin. Terrific talk, and I look forward to our conversation. And we've already got questions in the Q&A box, so I encourage others to add their questions there. We have a wealth of resources within the AMA to address how to create the organizational foundation for what you've called the MVP of wellness. Joy, purpose, and meaning in work would be another way of stating that. And so we've linked to some of those resources here, and that will be posted online. I've put a few links in the chat to Dr. West's article, to the NAM article, National Academy of Medicine article that was mentioned, and to the Forbes articles. So if you want to get at them right away, go in and grab those links. And then if you will, next slide, Colin. And we've got some exciting upcoming programming that we'd like to let you know about as well. Dr. Marie Brown, who's the Director of Practice Redesign at the AMA and a recently practicing internist, will be presenting and leading a discussion on medical assistants, recruitment and retention. And that's on February 17th. And on March 2nd, we'll have Dr. Elizabeth Harry talk about cognitive workload and whether that's a modifiable physician burnout, contributor to physician burnout. And when we think about cognitive workload, we think about, why does my brain hurt so much at the end of the day? So we'll look forward to both of those. Colin, thanks so much for that presentation and for setting that context so clearly about why this study mattered and then about what we learned. And I keep thinking, when I think about the message you've given us, that while burnout manifests in individuals, it originates within institutions. And in that Forbes article that you were interviewed for, you talk about resilience. It's really been part of every doctor's toolkit from high school, college, medical school, and beyond. And it's actually a necessary part of our professional service to our patients. Today, you talked about misdirection of organizational solutions when they're aimed at the individual can contribute to cynicism. So why do you think it is that many leaders move first to focusing on individual efforts to reduce burnout?
Yeah, it's a really foundational question. And I'm going to start by saying something that's maybe going to strike some in the audience as a little controversial, and it may take a bit to think about it. But I start from a contention that most leaders in medicine want to do the right thing. And I think it's really important to keep that context in mind. It is uncommon in my experience, I would say downright rare, for leaders in medicine to be actively trying to make their physicians' lives miserable. It's not their goal. They're not sure how to connect with the right solutions, however. And that's, I think, where the attractiveness of some of these individual focused solutions comes into play. Because if you think about it from a leader's standpoint, organizational science, shifting culture, implementing large organizational shifts in policy is really difficult. It's hard to turn the Titanic. And at the individual level, on the other hand, there is a wealth of resource available to help people with stress management. There are tutorials to improve your ability to function individually in your electronic health record, for example. There are resilience training courses. There are apps. And you can say as an organization, hey, we'll connect you to all of these things. And I think the temptation sometimes is mostly out of naivete rather than malice to say, we've got a well-being program because we've connected our physicians with these resources. And they haven't stepped back to that larger view of, okay, great, we've connected some individual resources with our physicians. That helps us with this individual aspect of the drivers of distress. But remember, this is a shared responsibility, and we've got to populate the menu for that bigger piece, that organizational contributors piece. And I think it's partly being paralyzed by how big the challenge seems, and not being able to take that first step. Sometimes it's not knowing how to take that first step. And sometimes it's because the individual solutions feel easier. And I think the cynical response that every physician, I will put myself in this camp as well, has experienced at some point in our careers is this reaction of, well, yeah, of course that's easier for you. You're not doing any of the work. You've made me have to get better to deal with my environment. It's the canary in the coal mine where the solution is to have a stronger canary rather than fixing the darn coal mine. And again, I think if we frame that from a perspective of our leaders, whether physician or non-physician, really in the vast majority of cases, we have common cause. We share goals of wanting to connect our patients and our communities with better health themselves. And we may have different understandings of what that means. We may have different depths of sophistication of background around what the drivers of distress are and how the current system is actually getting in our way. But I think if we can start with that sort of generous approach of, we do have a shared purpose, and let's then build on that shared purpose and advance our common education around the importance of really tackling the organizational approaches together. It's not that resilience is bad. Resilience is good. We all need it. But we don't need resilience to be shoved in our face to say, you're not tough enough for this, get better, when that's really not what the bulk of the problem is for most of us.
So really good, and thank you. And I want to underline this before we get to some of the very specific questions that people have in the chat. In your Wellbeing Wednesday Twitters Twitter threads that I want the audience to know about. So I think it's hashtag Wellbeing Wednesday. In one of your recent ones, you said our focus should be not on fixing broken individuals, but on fixing broken systems to optimize performance. And that really, I think, captures this also.
One quick thing, and I know we'll get lots of questions coming in here, but one quick point I will make as well is people are familiar with the quote from Paul Batalden that every system is perfectly designed to get the results it gets. And that applies to well-being just as it applies to patient safety and quality. The analogies are there, and we need to think about this the same way. Well-being is really a quality issue. It just affects not just our patients, but ourselves, our colleagues, our physicians. We don't have to walk completely new paths to connect with our solutions, but we do have to appreciate that these are systems driven, just like we had those discussions in To Err is Human from the Institute of Medicine, the precursor to NAM, now more than 20 years ago.
So let's dive into some of the specific questions. I think we may have some researchers on the call. And so a few questions. The first one that came in was around, did we stratify by gender? And we did, and I happened to pull it up in case you didn't. So, but do you want to talk about the stratification by gender?
Yeah, actually, I'm glad that you took a look at that because I don't remember what the resilience data looked like by gender. I will speak to the burnout, but I wonder, Chris, if you can jump in with the resilience, that would be terrific.
So I did pull it up here, and we did look at that by gender, and we found that women had an odds ratio of 1.33 of resilience. Let me just make sure I'm reading this properly. Yes. So multivariate, I'm going to have to ask you to help me fill in to make sure I'm articulating this correctly. But in table 4, when we did the multivariate analysis, women had an odds ratio of 1.33 of resilience relative to men. I'm actually having a little trouble myself answering. The males were 1.0.
Yeah, and I don't have the paper up in front of me, so I'm going to
apologize. I thought I had that down.
So maybe I'll back up a little bit and just say, from a resilience standpoint, it's a great question. I'm delighted that we did look at it, and I don't remember what we found, but it will be in the paper. I will speak to the burnout piece of it, however, because this is actually a nuanced discussion. Almost every study that's ever been done of burnout that's looked at male-female patterns has found higher burnout levels among women, particularly in the emotional exhaustion domain. Now, it turns out it's a little more complicated than that. And we dug into this last year with one of my colleagues, Ariella Marshall at Mayo, leading a paper on not just looking at burnout by gender, but digging into other structural factors. We know that burnout differs by specialty, for example. We know it differs by practice type and the local environment that people are in. And it turned out that once we adjusted for those factors, specialty, number of work hours, type of practice, reimbursement plan, the differences between men and women went away. They were largely explained by those structural differences. So there's almost a gender analogy to our structural determinants of health that we think about in public health when we think about burnout. So it's simplistic to argue that women are simply at greater risk of burnout because of something individually intrinsic to being female. It's actually what we do to incredibly dedicated, passionate individuals within the environments that they either choose to work in or, more concerningly, are funneled to. And there may be biases in those directives in terms of picking which careers women are more represented in. And we need to take additional care to make sure that those organizational environmental factors in those structural settings are more attentive to the work experience so that women don't have to experience more burnout simply by being in one of those professional domains that seems to set them up for distress.
So, Colin, I did look at that table a little bit more closely, and it's a table looking at the association between physician resilience score and burnout symptoms. And it was multivariate, and women had an odds ratio of 1.33, which I would take to mean that there was a tighter association for women, with men being the reference at 1.
Yeah.
So let's move on. There's a question that I think is related to what you were just saying with respect to burnout by gender is really complicated because of potential confounders. This person asks, are resilience and burnout confounders? If so, how?
Yeah, another great question. And I will, I'm going to stay away from the methodological epidemiologic definition of confounding and treat the question a bit more broadly. And the way we think about resilience and burnout, I think, has analogies to how we think about burnout's relationship with other dimensions of well-being or distress. So there's been a lot in the literature about what's the relationship between burnout and depressive symptoms, for example. And we've contended, and we've got very strong data to support, that burnout and depressive symptoms are related, but not the same thing. Burnout and resilience, burnout and job satisfaction, it is clear that they have overlapping Venn diagrams, but they are distinct. Burnout and resilience are interesting because neither of those is a DSM-5 diagnosed illness, if you will. They are psychological experiences or characteristics that individuals experience. And so it makes sense, and the data show this, that resilience may be protective against burnout. Burnout is a chronic work-related response to stress where there's an imbalance between the demands that are required for a job and the resources available to meet those demands. So resilience may allow people to better tolerate disconnects between those resources and those demands, at least for some period of time. And so it makes sense that the more resilient someone is, perhaps the more resistant to burnout they may be. But what our data suggests is even the most resilient people aren't immune. And so resilience can't be the only solution. The relationship, there is a correlation. It's an inverse correlation, higher resilience, lower burnout. Psychologically, in terms of the development of the constructs, they are different things. Burnout, again, that chronic reaction to disconnects between demands and resources. Resilience, that collection of qualities that allow someone to adapt or even thrive in the face of adversity.
Terrific. Here's a question that links to one of the topics you were talking about a little bit earlier, when you said you think you'll be controversial, but really most leaders, almost all really want the best for the physicians and for the patients. And first, I'll just underline that. A few years ago, we brought together 10 CEOs from some of the largest institutions, and Dr. Noseworthy of Mayo and the CEO of Cleveland Clinic were the two co-chairs of that. And then we had other large, well-regarded institutions present. And so the question, and we thought we'd have to convince them that burnout was a problem. They said, you've got our attention. We know it's a problem. Just now help us figure out what to do. Help us understand what will make a difference. So the question this person asks is, how many healthcare organizations tie CEO salaries to a level of physician satisfaction? And I will share with you that in that meeting, 2 of those CEOs did identify that they have asked their boards to hold them responsible, to hold a portion of their compensation to be related to improvement in the well-being scores of their most at-risk departments. So with that as a question, do you know of other healthcare organizations that tie leadership compensation in some way to an outcome relative to workforce well-being?
Yeah. So we've advocated for a long time that the employee experience should be part of the dashboard evaluating a CEO's performance. I would, sort of pulling back the curtain a little bit in the CEO world, I am not a CEO, but knowing what I do know about some of those, there can be a difference between what's on paper and what's actually enforced. And I think a first step is to get things on paper, but we need to continue to push for something that's got a little bit more action behind it. When we talk about the words around this, having performance dashboards that include employee and physician satisfaction in particular is important, because if it's not measured, it's easy to deprioritize or lose it relative to other elements of that dashboard. It's very easy for clinician experience to get pushed to the side when it's not on the same page as the margin or the NOI of the organization. It's also easy for, again, well-intentioned leaders to argue that the NOI is necessary to deliver well-being and put the cart before the horse, not recognizing or losing sight of the fact that the NOI is causing distress that then in the long term is not a good business strategy, because you increase turnover, you reduce FTE, you reduce the culture of engagement and discretionary effort within your organization. So in my experience, there are an increasing number of organizations that are looking to get these well-being metrics onto their dashboards. There are very few that have actually put teeth into that or had a financial stake in it. And I have mixed feelings about that, because on the one hand, I think it would be helpful to have something that is really, that's pretty strong accountability when it's your own take home that's being impacted. On the other hand, I actually think it's more important that organizations implement the strategies and be aligned in helping meet their employees deliver meaning, values, and purpose than it is to hit a specific target number. And I worry a bit that we start to get into dashboards that we've seen in patient care, for example, of meeting a quality metric where the metric becomes the goal rather than what your true goal was at the beginning. And surveys get gamed, tools get put out to deliver a certain goal. Short-term goals can be delivered at long-term cost. This really needs to be woven into the strategic vision and the culture that an organization is looking to sustain, not over a quarter, not over a year, but really over decades. And so I think some combination of weaving it into the fabric and having some real accountability is probably where the sweet spot is. Short answer, very few organizations that I think are doing this aggressively, but an increasing number of organizations that are really trying to have this be a consideration. And that's a start.
Yes. And I'll put in the chat a commentary, creating a manageable cockpit, a shared responsibility, where we argue that not only the CEO, but if the CEO in turn makes the executive leadership team, makes their compensation in part dependent on the well-being scores, people will make different decisions. As a compliance officer, you may always say no if your only responsibility is to protect the organization from a compliance audit failure, but you may make different decisions if your responsibility is over the doability of the work and the well-being of the workforce. I'd like to switch now to another, I think, more scientific question, asking, so for physicians who have high burnout, can that itself lead them to rate their resilience as low rather than it being the other way around? And of course, we know that this is association, not causation. But you did tell us that we as physicians aren't that good at self-assessment. And so maybe you can speak to that question.
Yeah, it's a really good methodological question. And the most honest answer is we don't 100% know from the cross-sectional analysis what's driving all of the responses. And we do have some longitudinal work going on to get a sense of, when people experience changes in burnout or resilience, what impact does that have on the other factor? And so that'll help clarify some of these questions. This has come up in other work as well, that when we look at burnout, do individuals experiencing burnout rate other aspects of their work lives or their personal lives more negatively? And although that's intuitive, we've actually seen very little evidence of that in most of our other work, and it hasn't borne out as much as even we might have thought in the longitudinal analyses that we've done. But it remains a concern. If you view the world negatively, you view the world negatively. And if burnout makes it difficult for you to see positive aspects of the environment because the environment is a weight on your shoulders, it does stand to reason that some other self-reported subjective domains may end up also looking more negative. Now, that has to get counterbalanced with the notion that physicians, as Chris alluded to, overrate their well-being to begin with. And so even burned out physicians rate their well-being as being better than that of their peers. Again, my colleague Lottie Derby has studied this. 90% of physicians rate their well-being as better than the well-being average of their peers. Now, I'm in Minnesota. I'm in Lake Wobegon territory, right, where everyone's above average. But as a statistician, 90% of people cannot be above average. We are upweighting. And to make that point even more strikingly, of the physicians in those studies who were in the bottom 30% for well-being measures, 70% of that bottom 30%, or 70% of that bottom 30% rated their well-being as above the average of their peers. So even the people who have the lowest well-being are still actually thinking, yeah, it's horrible, but I'm better than my peers. And maybe that's keeping them afloat, this idea that they're staying above average. But we need to be more self-aware. How much that impacts the relationships in cross-sectional studies is an open question to an extent, though. So I want to be intellectually honest in responding to the question that the cause effect and the impact of one variable on another, which I think ties back to that confounding question as well, is something that we need to continue to clarify.
So there's several questions here, Colin, that have to do with where do we start? So if we wanted to start a program for wellness, what's worked? This person has heard of things like rewards and appreciation, mindfulness, gratitude journals, food, but maybe you can expand a little bit more on some of the more systems approaches that show promise to relieving clinician burnout.
Absolutely. And so I think, the introduction to this is, first of all, to know what works, you have to understand your people. And the solutions are very local. So a top-down leadership approach, which again, we talked previously about the appeal of relatively simple strategies, a top-down one-size-fits-all approach rarely works. So that's a caution. When we think about the drivers inform the solutions. And so when you look at your local work units or your work areas, and this doesn't have to just be physicians, this can be interdisciplinary, this can be other healthcare professionals as well. Think about, in that broad menu of drivers: workload, work efficiency, work-home interference, values, community. These have been published on the NAM consensus report. Is a resource that I think everyone should download a PDF of, because it's just invaluable in describing the state of the understanding around the drivers of well-being and distress. If you target those drivers and put those in front of your local work group and say, hey, is it workload for this group? Is it work efficiency? Is it sense of community that's eroded and we need to restore? You can then focus where you're going to get the most value, because your constituents will have told you what they need the most. And then within that, so the first organizational approach is assessment. That doesn't mean just surveys. That can mean focus groups. That means safe spaces for people to voice their opinions. That means, and there was a chat comment to this effect as well, that means that you need to truly value feedback that may seem negative. There's a quote out there, and I'm sorry, I'm not going to attribute it because I can't remember the individual's name, but a leader should never be more afraid than when his or her most passionate individuals fall silent. Feedback is good. It tells you how you can get better. And when your constituents are telling you what needs to get better, don't view that as complaining. View that as an opportunity to partner, because that's your path forward. And so if leaders can embrace that, and it does take some humility as a leader to step back and be vulnerable and say, I don't have all the answers. I want to help us get to a better place. Then you can engage with your local work units. We're big on the concept of shared responsibility. So we've worked on, for example, facilitated small groups where the organization provides resources, the individuals provide time and energy, and then together they work toward building community, tackling tough issues, being solution focused. But at a 30,000 foot view, assessment, recognize that solutions are local, and look for partnerships with leaders. That's how you start, and let the evidence base guide what those domains need to be.
Well, I want to first thank you for that answer, then tell our audience that I did put a link in the chat to Steps Forward resources. These are free online toolkits with topics that address many of the questions. One of my favorites is called Getting Rid of Stupid Stuff. It's about intentionally de-implementing policies that have no longer have their value, and listening, as Dr. West said, to what the local experts, that is the clinicians, are suggesting need to be de-implemented. And with that, I want to...
I would just, one quick comment, Chris, I know we're at time, but Christina F. in the chat, for those of you who can see that, has posted, I think, an absolutely brilliant comment about an approach for how you start. Understand the current state, develop a business case, help leaders understand why this is an investment that's both a moral argument and a financial argument. And I guess it was sent to the panelists. I wonder if we're able to cut and paste that or share it with the larger group. Others are saying they cannot see it.
We will add that to the resource.
Good, now it's been sent to attendees. Some of these comments have been going to the panelists, but we can extend it to the attendees. It just got posted. Thank you so much to our AV team.
Yes, and thank you, Dr. West, for your time today, for your research that you do, and for all the intellectual rigor that you bring to this very important topic.
Thank you. Thanks to all of our attendees for the great questions. And please don't be shy about reaching out if I can address questions that we didn't get to as well. Thanks, everyone.
Thanks, Colin.